Good morning, everybody. Thanks so much for being here today. My name is Francisco Bonilla-Escobar. I'm going to be presenting my PhD work, the dissertation titled Teleophthalmology to Prevent Diabetic Retinopathy in Western Pennsylvania, Implementation, Outcomes, and Associated Factors with Loss to Follow-up. The director of my dissertation is Dr. Waxman, and the dissertation committee is Dr. Cuyana, Dr. James, Dr. Smith, and Dr. Gere. Thank you so much for the people that is tuning in Zoom. So some disclosures. This presentation does not receive any commercial support. The authors declare no conflict of interest. The content was developed independently and without interest from any commercial entities. The funding sources, Conciencias, MinCiencias, the Ministry of Science, Innovation and Technology of Colombia, of course, the School of Medicine through the Dean of the school, and the Ophthalmology Department. And the data and conclusions presented are solely the responsibility of the authors and have not been influenced by commercial interest. As we're going to talk a lot about cameras and devices, so I wanted to make sure that we're on the same page. So diabetic retinopathy is a humongous problem, not only in the US but around the world. It has costs that goes around 11 million to 3.9 billion in Germany of annual direct and indirect costs. And it is crucial to recognize the paradoxical nature of diabetic retinopathy, as it is preventable and treatable. It is one of the top 5 causes of blindness worldwide. In the US, among the working age adults, is the first cause of blindness. And it affects around 4 million of Americans total, and its prevalence is predicted to triple by 2050. It has the second higher cost for visual impairment in the country after age-related macular degeneration. And there are disparities in the distribution. We know that it affects mostly ethnic minorities or people in lower socioeconomic status. But what we know about prevention of diabetic retinopathy? And so everything starts with in-person screening. So it means that an ophthalmologist or a primary care doctor will look inside your eyes. As you can see in the photo, it's a little bit challenging without practice to do these kind of exams. And screening rates vary depending on the region. They go from 25 to 50%, but still saves around $100 million per year doing these exams in terms of blindness. In a study comparing ophthalmoscopy carried by ophthalmologists, compared with 7 field fundus photographs, meaning that almost a big part of the retina was covered with these photographs, they found a sensitivity of 34% and specificity of 100%, which left a lot of people without being diagnosed just with the direct ophthalmoscopy. And so in 1985 is where the first reports came about retinal cameras, and they changed the landscape, but just a little bit. So we know that screening rates have changed from 50 to 60% with retinal cameras, that they save around $785 per person, with a high sensitivity and specificity, waiting time reduction of 89%, and of course they have increased the opportunity to be in screening for patients. A recent study published in Nature in India showed that it also have an impact in the environment, saving 2.89 kilograms of CO2 production per person, which kind of means 7 miles of driving related to the US. And so, when talking about the conceptual framework of the study, I consider the prevention model, but also model with barriers. And so, our project is focusing on secondary prevention and tertiary prevention. Secondary prevention is the detection of the diabetic retinopathy, and tertiary prevention is about treating the diabetic retinopathy. And so we know that there are barriers that are specific for the patient, the providers, or the healthcare system, and they are mostly related to cost, the type of insurance, transportation. But how the process goes? So a patient visits a primary care clinic, gets their eyes imaged, and this is an example of one of the machines that we have in the program. It's a DRS center view, the old model. It takes less than 1 minute to get the eyes imaged. It's 1 photo per eye, starting with the right eye and then the left eye. These photos are sent to the eye doctor or a reading center where they are reviewed and then sent back to the primary care clinics to be reported to the patient. And this process can be done through email, through a platform in the cloud, or through the electronic medical records. Our program has evolved over all these steps to finally be settled in the electronic medical record. And talking about tertiary prevention, this is where follow-up takes a role of importance for the project. And when patients are screened, it is important that people that have a positive exam or an indeterminate exam are seen by an eye doctor so they can be treated. And again, they have similar barriers in terms of patients, providers, and health system. We know that a third of the people after screening requires a follow-up. And this third of people is divided among those with visual diabetic retinopathy, other findings like glaucoma or age macular degeneration, and indeterminate exams. So these programs are not only important for diabetic retinopathy, but also to detect other diseases that are vision-threatening diseases. The problem with those is that most of the chronic ophthalmological diseases doesn't present symptoms until they are very advanced or late. And so with the cameras, people have access to be detected or to be found positive for other diseases, even though they are not expressing the disease. And diabetes is also associated with the development of other chronic diseases of the eyes. About indeterminate exams, they are an important part of this third of people that require follow-up. They could be due to opacities in the cornea, the lens of the vitreous, or small pupils. And these opacities can be diseases, cataract, for example, or a vitreous hemorrhage, or can be physiological, like somebody like me, I have a pupil that is 3 millimeters, so my photos are always a little bit dark. But diabetic patients can develop autonomic neuropathy. And so we think that people with indeterminate exams can have some disease in the back of the eyes. And the follow-up rates also have changed with teleophthalmology. So similarly to the screening rates, when somebody is in a program with ophthalmologists alone, follow-up is 50%. With teleophthalmology, follow-up is around 60%. There is little literature, around 11 papers, as far as we know, that describe associated factors with follow-up. And they can be divided among socio-demographic and socioeconomic, clinical factors, and systemic level factors. Some of them are proximity to eye care, insurance coverage, severity of retinopathy, higher rates of follow-up in non-Hispanic communities, being an older age group, utilizing artificial intelligence, male patients living in rural areas, and also self-efficacy. And so patients that are aware of their HbA1c levels, or patients that don't need help scheduling an appointment, are more likely to follow up with eye care. So we're solving 3 gaps of knowledge in this dissertation. The first one is to get to know the point of care diabetic retinopathy examination program. There is documentation on how to create a program made by the American Teleophthalmology Association, but we know little about practical experiences of how to implement programs, what are the hurdles implementing a program, and what challenges also a program can face while it's developing or evolving. We also know little about the outcomes of the program. The second gap of knowledge is follow-up rates. Post-screening, there is a scarce data on patient adherence to follow-up after screening, and it's important to measure program effectiveness. And finally, we wanted to know more about factors influencing follow-up. So the first question is, what is the history and outcomes of the POC-REP, the point of care diabetic retinopathy examination program? We tried to identify the program evolution through a quality improvement project that started before I arrived in the program. We did interviews with key stakeholders trying to identify with ophthalmologists, primary care physicians, staff, how the program was brought to their clinics. how they get to know about the program, and how it was evolving. We also review the program materials. So any report, email, guideline that existed from the projects were reviewed to understand what were the instructions, how was the program implemented, etc. And we were able to build a timeline from inception to 2020. In the quantitative part, we review medical records to obtain data from 2008 to 2014, and automatic reports from 2015 to 2020. And consolidated this data in a single database. We analyzed a small set of variables as we wanted to be able to talk about the whole timeframe of the program. And there was a lack of standardization back in 2008. So we have little variables, but we attempted to measure socioeconomic status based on the zip codes. And so the Census Bureau has databases where they describe the mean income per zip code, and they also describe how to qualify that income into poverty levels. And we did a descriptive analysis of this data. So I joined the ophthalmology department in 2017 after working with Dr. Puyana in implementation science and trauma registries for 2 years. And when I arrived to the program was called the Gorilla Eye Service Reconnaissance Project. There were 12 cameras there, and I was hired as a project manager coordinator in that time. Then we started to build this timeline, right? So in 2016, Dr. Chantal Villalobos, which is family medicine now, she, with Dr. Watson, developed this quality improvement project to identify follow-up rates and to work in the program to understand how to make it better. As you can see here, there were around 100 photos per month in that time. And so I started to go backwards to identify what was happening in the project before. And so everything started in 2011 with the Gorilla Eye Service Initiative. So Dr. Watson, in company with medical students, residents of the ophthalmology department and other faculty, they had the Gorilla Eye Service program, where they were visiting underserved communities, primary care clinics, free clinics, being the eye doctors of the patients of those communities. And they found out that most of their patients were diabetics without their eye exams. And so they decided to implement a camera in one of the free clinics, McKeesport 9th Street Clinic. This is a free clinic that works once a week, and volunteers in that clinic borrow the camera from those clinics and put it into their own practice to test this experience. This is the case of Lateran Family Health Center. And through a word of mouth, this was a new technology that was growing around. Several different clinics joined the effort. We have the St. Margaret Family Medicine Clinic also joined, getting Lawrenceville, Bloomfield, Garfield, and New Kensington Internal Medicine in McKeesport also joined, and federal qualified health centers and other free clinics joined, including Birmingham Clinic, Northside Christian Health Center, and I'm forgetting the name of the one across Home Depot. Pittsburgh. Thank you so much. But this wasn't enough. We started to get a report, and in the report, there was this clinic that was popping out that I didn't know about. It was called Partners in Health. And so one day I drive to this clinic and I found out a fossil camera. It was a 20-year-old camera probably. It was a NITEC, not automatic, it was manual. And they were still doing photographs 10 years later after the implementation, because the same person that was trained to use the camera at the beginning was still working in that clinic. And this took us to identify the Department of Defense project, which was led by Dr. Eller. And we had 3 cameras in total. 2 were implemented in primary care clinics, Montefiore Hospital, Partners in Health. The camera from Montefiore was moved to University Center at Dr. Francis Solano's office, who is here today. And one camera was lead to the health plan to fill gaps in healthcare. And so now we knew where we started. We started in the GS, the Department of Defense, and then we adopted the Department of Defense program. We joined efforts with CMI and started a process of standardization of the project. And so, as in the experience of the program from before, I was happy to identify that there were spaces to improve the project process. And so Dr. Waxman changed the reporting system into this app for the readers to click some boxes and obtain a report that was standardized, and so that we make easier the analysis. As you can see in the map, we started in the middle of the three rivers in the eye center, and the program started to expand across all Western Pennsylvania. In purple, you see CMI, in blue, you see University of Pittsburgh Physician, and in green, you see non-PMC centers. But the program didn't stop there. We also moved to central Pennsylvania, going to Anvil, but also Erie and Susquehanna. And in one of the visits to Anvil is where we developed the case of the month. I was implementing the camera in Anvil near Hartford, and the first patient that walked in, completely normal, young person, we got this bright retinal vein occlusion. The patient was symptomatic, but this is a threatening visual disease. And so that helped me to sell super easily the camera to this community, because we found a disease in somebody that wasn't expecting to have anything in their eyes. And we did this to educate the community of doctors and staff that were participating in the program. And later on, we developed the program report, which was based on all the data that we had to identify trends and diseases and findings of the program, so the clinics would be aware of what they were doing. We reached 44 cameras, and the program skyrocketed in the number of screenings. This was thanks to a community effort with CMI and also all the community of doctors and staff in the clinics that helped us to grow the program so much. And around 2019, the program changed to point of care diabetic retinopathy examination program, where we hired a program specialist to keep the quality of the project. And this is the latest projections. My projection goes on to here. These are the latest projections after the pandemic. Of course, the program went to zero, then recovers. It's still around 400 images a month. And this is from the Doctoral website, which has the numbers of the program for the clinics to consult. A very useful tool to keep up with the project. So what I was doing when I was visiting the clinics, not only implementing the cameras, looking for barriers, but also how to overcome them, but also was training the staff, so I'll carry a tablet or a phone with photographs, and so I can show the people in the clinic how we needed to do the screening and what were the photos that we needed to be sent to the eye center. And so we will go over several different types of photographs that they will send. The top ones, photos with fingerprints, for example. The second one is photographs of a blink, patient looking elsewhere. These are hairs. One of these I see, the other one is smudged in the lens, was cleaned with not the proper cloth. This is the lens cap. Photos of other parts that shouldn't be there. Small pupils, and also what they could find as disease. My hope was, and I was doing this like not for the research, but for the patient care, to teach the people doing the photographs that they could also see disease, and they could help the patient to schedule their appointment faster. But also what kind of photos we wanted. So the readers in the eye center could have good quality photos and send back reports that were worth it. We also developed patient information flyers with the help of CMI. This was a previous version of it, trying to inform patients about what diabetic retinopathy was and how to prevent it with the cameras. And in terms of the outcomes, we conducted a total of 21,000 960 exams in those 13 years. Most of them read by Dr. Watson, with 16,400 unique individuals screened in the program. Some of the demographics of the population, the age was around 60 years, females were 46%, with a 65% of white population, Latino was 1.5%, and diabetes type 1, 2 was 93%. In terms of exams, there was people that have more than one exam in their whole time within the program. And we have up to 70% of people that have 2 exams. For example, the insurance was between Medicare and commercial 30%, and 6% of people was under the poverty line, also with high BMIs and high HbA1c levels. In terms of the outcomes of the project, 86% of the images were gradable, 69% were within normal limits, 20 to 30% were positive for diabetic retinopathy, as you can see in the red line. Around 10% were indeterminate with some changes. As you can see, the indeterminates started very high at the beginning of the program, then went down and escalated again. And almost a third of exam resulted in a follow-up recommendation with 6% in vision-sparing diabetic retinopathy. And of course, the other findings that included glaucoma suspects from 2 to 10% and 2 to 7% for age-related macular degeneration. So what have we learned of this first outcome or question? There was a unique emphasis of this program in human factors. The program was spread through a word of mouth, through a community that was helping each other to build or to apply for grants to get their cameras. There was an extensive data review of 13 years. We were able to standardize the workflow for high reproducibility. So whenever a clinic wanted to implement the camera, we have built all the procedures for them to easily implement the camera. It was a participatory approach, so we built a community between the primary care sites, and it was implemented across diverse settings. As you hear, UPNC, UPP, Federal Qualified Center, and free clinics were part of the project. And in terms of patients, there was sort of an equal gender distribution, broad age range, diverse population groups with Latinos being represented in the project too, and high prevalence of obesity and uncontrolled diabetes. So the next question was, what happens with patients that are recommended to follow up? And so we designed a cross-sectional study from 2015 to 2018 with data from the exams from the electronic health records. Our aim was to examine follow-up rates and associated factors. We included 31 practices with 31 cameras using the Center View DRS of the Topcon, TRC, and W400. And follow-up was defined as a documentation of an eye exam with an eye doctor within UPNC. So these will be in the medical records, a report scan from outside providers, also in the medical record, or physician notes addressing the exam, talking with the patient over the phone or with a visit about the completion of the exam with the eye doctor. The success was an appointment within 6 months, and we also collected findings for indeterminate patients that were seen at follow-up. We carried out a multi-level mixed effect logistic regression, clustered by site and individuals, as we believe that sites cluster particular individuals, and so they have similarities, but could be different from other sites. So we think clusters, and it was an important variable to adjust for variables that we weren't able to measure, and individuals because they were imaged several different times, so we have some variability between the individuals. We have 6,200 individuals with similar profile as previously described in the outcomes of the whole program. 1.5 Latinos. We identified 10% of people from poverty areas, and similar distribution of the insurance and the BMI and HbA1c. In total, there were carried out 7,700 periodic examinations, diabetic retinopathy exams, and the gradability was around 90%. And we found that there was a high proportion of non-gradable left eyes compared with right eyes, 10% versus 8.5%. And this could be procedural, as the camera goes from the right eye to the left eye. Maybe we don't have enough time for the left eye to dilate after the photograph because there is a flashlight that contracts both pupils. And so this finding was significant. The prevalence for diabetic retinopathy was 11% and almost 6% for vision-threatening diabetic retinopathy. And we found other diseases than the diabetic retinopathy in around 14% of the exams. Other interesting finding was providers participation. So out of 727 providers, these were all the people that were ordering the exams, we found that half of the exams were ordered only by 15% of them. In terms of follow-up required, 1/3 of the people required follow-up, and 30.9% of them had a follow-up within 6 months, out of which 57% were seen in UPMC. So we have 43% of people that were confirmed have follow-up outside the PMC network. The time to follow-up had a median of 55 days, and we found out that there are shorter times for branch retinal vein occlusion or vision-threatening diabetic retinopathy. And if you can see in the table on the right, indeterminate exams have a longer time from interpretation to follow-up. In terms of follow-up rates, there is a higher follow-up rate for patients with BRVO and BTVR compared with indeterminate exams, which almost double the rates. We also look, as I said, for the results of what patient had if they had an indeterminate exam, and we found that 33% of them follow up, but surprisingly, 64% of them had something in their eye undetected in the diabetic retinopathy examination, with 12% having vision-threatening diabetic retinopathy. As you can see, also we found 13% of glaucoma and 36% of cataracts in these patients. In terms of the associated factors with follow-up, the data wasn't that strong, and so our associated factors were limited to 3, particularly described here, being in the group of 65 to 75% was associated with a 70% of likelihood of follow-up, being married, and having a severe diabetic retinopathy. So the program aims to detect, diagnosis, and refer patients has been accomplished with the number of screenings that we carry. There are still limitations in terms of the follow-up that we are reaching. There is an extensive use to the program in diverse primary care settings and in a wide variety of patients, including underserved communities, which are most likely affected by diabetic retinopathy. In terms of the program effectiveness, we have a high rate of interpretable images with around 90%, and comparable rates of diabetic retinopathy and vision-threatening diabetic retinopathy with the literature. In terms of provider participation, that the 50% of them ordered half exams called for an attention. There is a disproportionate exam ordering, and there is a potential bottleneck on providers on who is ordering the scans and why. Maybe there is resistance from DRE. Some qualitative studies from the patient's perspective said that the patient would like to continue their in-person relationship with their ophthalmologist. Maybe this has reached the doctors, we don't know. So we are lacking studies to understand what's happening with the providers instead of their recommendations. In terms of the gaps that we're addressing, congratulable images, high incidence in the left eye, call for procedural causes and a quality improvement project to review the quality of the photos. In terms of follow-up rates and indeterminate exams, there is as far as we know, there is no evidence of what happened in patients with indeterminate exams after they get follow-up. And or associated factors with aging, merit, and severe DR provide little information on how we can prevent from public health initiatives diabetic retinopathy. There is a rapid interpretation of the images. Most are read within 24 hours. But it would be interesting to assess the relationship between time from exam to reporting to the patient to follow up. And beyond diabetic retinopathy, 23% pathologies were found in this study, which are aligned with others' research. So it's very important to address indeterminate exams, as we found 60% of them, or those that follow up, have disease in their eyes. There is importance to continue education incentive program both for patients and for providers to order the exams and personalized approaches. And associated factors found in this project, including older age, BMR, or severity of diabetic retinopathy, could be addressed through social and familial networks improving, or work towards groups or social networks. Sorry. Next step, a broader variable inclusion to identify more verifiable factors affecting follow-up. And so, last question. And we got to know the program outcomes and how it evolved. We got to know the follow-up rates and a little bit about associated factors. And so now we want to measure what are the associated factors that influence whether a patient follow up or not after an exam. And there is a wide variability in the literature about follow-up and the follow-up issue. Some studies said have reached a follow-up rate of 8%, some studies have reached a 70% follow-up rate, but these studies have several different limitations. We know that there are different factors influencing adherence, including sociodemographic and socioeconomic, clinical, and system-related factors, as described in the figure, but the research finding these has several different limitations. Small sample size in many studies, reliance on interviews, studies conducted outside the US, analysis of a specific population, say Latinos or Black communities, or focus on patient characteristics and not program-related factors. So this compartmentalized approach hinders the full understanding of barriers towards follow-up. So we analyzed data from the POCRED, addressing the limitations, trying to address some of the limitations of previous research, doing a comprehensive evaluation of sociodemographic, medical, and system-specific factors to identify high-risk patients for nodal adherence. So we got a database from 2017 to 2019. There were around 12,000 patients screened in that period, but out of them, 3,000 people were required to follow up. Were older than 18 years of age and were examined by the POCRED, of course. We included those with vision-threatening diabetic retinopathy, other pathologies that require follow-up, and those with indeterminate exams. And excluded repeated exams within a year, diseased individual, and non-repeating network size. And the exclusion of the latter, was because some of the other places outside European Sea were not fully implemented or not were continuously collecting data. Besides the difficult access to the medical records to gather information about follow-up. For the dependent variable was follow-up attendance within 6 months after the exam, and independent variables are described here, but most importantly, I want you to focus on the system-related variables where we collect the dates to identify different times, time from exam to reading, from exam to report, from exam to follow-up. The image quality, the insurance type, the no-show rate, the contact attempts, and the type of contact, and the outcome of the contact. If it was made from the eye center, from the primary care, how it was made, and if it was successful or not. We look at the automatic reports from the POCRED, but also we did an electronic medical record search using EPIC. We extract the demographic and socioeconomic variables from the program reports. The clinical system variables were manually extracted from the EMR. And the data collection strategy, we review the electronic medical record to identify follow-up encounters. We double-check this variable by a different researcher, and then we identify the discrepancies between those two variables and resolve them by an experienced team member. And there was also a rigorous quality control measure on the problem list and the DRE variables. So we address bias, or attempted to address bias, by a meticulous validation process for the electronic medical record data with double checks. We standardize the procedure to minimize missing data, particularly the follow-up variable. We determined the sample size based on our previous research that identified a 30% prevalence of people following up, but also what is the risk for following up or not following up if you have vision-threatening retinopathy. We did univariate and bivariate statistical analysis to describe the data, but also based on paper 2 or on the previous research, we also built a multi-level mixed epidemiologic regression with clusters. And for this model, we selected the independent variables based on a literature search, but also using simple regressions with a p-value cutoff of 0.20. And we also explore a survival analysis of time to follow up based on a stratified data by the days of the patient being reported that they needed to be seen by a doctor. So we gathered 3,000 people, 2,900 unique patients, 35 primary care clinics, similar demographics as described before. And the number of patients that followed was 32% in 6 months. We developed one model per each group of variables, so this is the combined model results. And so as you can see, higher the age, the higher the risk to be lost to follow-up. Being unmarried increased the risk for not follow-up. History of eye disease was a protective factor for loss to follow-up. Being communicated via personalized approaches, email, letter and telephone, or phone call were protected for being lost to follow-up. The days from the exam to being informed about the results also came up significant after 2 days of the exam being carried out, and the no-show rate. So an increase of every percentage in the no-show rate increased the risk for not following up. When we did this survival analysis of following up, stratified by the days of reporting or being reported about the exam results, we found a less likely probability to have a follow-up in the more than 3 days group. So reaching tertiary prevention in diabetic retinopathy, we found that age and being unmarried were associated with an increased risk of not following up. Previous research highlights similar findings, but in our study we are adjusting for other factors and using clusters, which hasn't been done in previous research. In terms of clinical factors, other studies have reported that diabetic retinopathy severity, and we also did it in paper 2, as you saw, a number of morbidities were associated. In our study, we didn't find significantly impact on follow-up of these variables. And in terms of system-level factors, receiving the result within 2 days and personalized outreach methods, meaning phone calls or emails, significantly improved follow-up rates. Longer intervals between exam and contact increase the risk for loss to follow-up. So there is an importance in timely communication and patient engagement strategies. So it's a highly reproducible program thanks to a robust workflow and a participatory approach involving primary care site personnel. It was successfully implemented in a wide range of primary care practices within Western Central Pennsylvania, serving both insured and uninsured patients, achieving a high rate of interpretable images and similar rates of diabetic retinopathy findings and other diseases comparable with other programs. The program also extends beyond diabetic retinopathy, as I was saying before. Around 20% of exams detected other pathologies that are vision-threatening diseases. This is one of the few studies that delves into follow-ups and associated factors with a large sample of patients requiring follow-up in a diverse setting. The referral audience fits within range of other studies that reported 10 to 60% of follow-up. However, 30% is still a low follow-up rate from our perspective. Patients with indeterminate results have diseases in the back of their eyes, so it's important that they have follow-up. Personalized communications can help to guarantee efficiency. We found that patients being informed through email, phone calls, or letters have a lower likelihood of being lost to follow-up. And being informed of the results as early as 2 days after the exams improves adherence. And so there is a recent study in Rwanda using artificial intelligence compared with regular reporting system. And of course, the artificial intelligence will take the picture and then immediately come out with a result. They found that they have high follow-up rates in this arm of the study, which could be correlated to being informed of the result of the exam earlier. The study limitations is transversal to the studies, the retrospective design, the use of an electronic medical record, and in terms of implementation and evolution, the lack of an early standardization in the program, potential biases due to missing information, and in the follow-up study, limitation in data available to test other study outcomes, for example, patient perspective or cell efficacy. We didn't have those variables in the study. For the initiatives and research, there is a need for qualitative studies to better understand the barriers to effective implementation and follow-up. We need to test studies to expedite processes and increase follow-up rates, maybe testing the implementation of artificial intelligence or lay graders in the program so people on site can grade the exam and tell the patient you need to be seen. And that conducting comprehensive cost-effective analysis, investigating the long-term outcomes, and conducting comparative studies of different follow-up intervention or strategies to see what is more effective. Program commitment to excellence, continuous improvement, and a comprehensive approach to diabetic retinopathy. It's evident in its technical advancement and the focus on the human factor. There is a well-defined workflow and collaboration with primary care personnel and that enable a broad reach to serve a diverse population in Pennsylvania, not only Western but also Central Pennsylvania, which we are very proud of. The program has highlighted the importance of proper follow-up for indeterminate or non-gradable exams, and this is the first time this is reported in the literature, as far as we know. And future research will include qualitative studies to understand perception, not only from the patient's perspective, but also from the provider's side, to understand what are barriers for follow-up. I want to thank my family, my friends, and mentor for their support throughout this intricate journey. The encouragement and belief in this work have been piles of perseverance. To the medical assistant, nurses, physicians, managers, and assistants, and administrative personnel in the clinics who collaborated with us and build a community around the program. Their openness to integrating diabetic retinopathy prevention into their practices has been fundamental in this collective effort to combat blindness in Pennsylvania. I really thank you for letting me into your lives and your clinics while you were working, opening time for me to be there, to implement, to talk, to interrupt, to get the program working. To CMI, UPB, UPMC primary care sites, Renaissance Family Practice, the health plan, federal qualified health centers and free clinics that work in the project, and to the people that let us be their healthcare providers. I got to know people from almost every corner of Pennsylvania. I try and share the memories that I spent with you all. Thanks so much.
Okay, Francisco, that was fantastic. Thank you very much for years of hard work and for the illuminating presentation and papers. Questions for Francisco? Yeah, from the committee first.
Francisco, that's a tremendous amount of work. Just looking at like all the stuff that you've done and all the analysis that you did with you know, a lot of data that you've worked on. It's amazing. And so I kind of like I more like kind of watch it for the last two papers. In particular, so in your description of the study design, you call this a retrospective, not retrospective, cross-sectional study. But you kind of like have a follow-up. You're looking at follow-up time points essentially. So I'm just curious how you kind of like, you know, because I think for me, for people who are reading the paper, it's important to know upfront what the study design is, because like for me as a statistician, kind of like think about, okay, what analyses I would be expecting from this paper, and then you know, if I see a cross-sectional study, okay, you know, we go to regression and things like that, and then you go to the third paper, you have survival data, you know, so kind of like I thought doesn't match. So I think that's one question. I was curious why you call it cross-sectional design, and if you think that's modified, how do you think you should call it, you know, the study design? I guess I'll start with that.
Thanks. No, that's a really good question that has been bugging me for a long time. The project, we started identifying follow-up in the medical records, and we have a snapshot of the patient's characteristics at their exam. So, for example, like HbA1c or BMI or the neurological rates, all of those were captured when the patient was being screened, being examined. And so that's why I don't have that timeline or this specific cohort design that is that clear to have measures in time, in the time, over the characteristics of the patient that I could be analyzing. I have just what the follow-up was when it happened, and what were the characteristics of the patient at the snapshot when they were examined. And so it's a very great thin line between a cohort study and a cross-sectional study. I still think that it's more a cross-sectional because of the fact that not showing the variables that we have, and not like a collection of data or a recollection of data going backwards. Yes, I think I'll leave it at that.
Okay, so I think I fully agree with you that you have snapshots of data at the time, and you did like kind of like a retrospective look at the data. But you have like kind of like a cohort, because you followed up with people who had the exam, looked at whether they had follow-up at 6 months. So in a sense, it's kind of like a retrospective cohort.
Yeah.
Is in my view, you know. So at least like because you know, when I work across sectional and then I see a survival, that kind of like doesn't align. You know, so just consider calling it a retrospective cohort design rather than a cross-sectional design. You know, I've done this a lot, you know, and because we look at like administrative databases, THR, things like that, and we look at the current situation and go back in time. So there's still a perspective nature. It's just that the way you collected the data retrospective rather than prospective forward.
Yes, I agree with you on those statements. Like, I think also the core will strengthen the design. It's a little bit higher in the freedom of evidence. And yes, I was troubled by the fact that the groups were established already. And then going backwards, but it makes perfect sense. Yeah, again, I feel like it's a great line between a case series and a core, but yes, that's a very valid observation. Thank you so much.
I mean, it's kind of like a minor, kind of like,
Yeah.
you know, thing. I think the other question I have is, going back to that survival data, so you did, in the third paper, you kind of like have a multi-level logistic model, modeling the finding outcomes, whether they have follow-up or not, right? And then you kind of like transition to like a survival model, which takes into account the time to follow up. I was curious about your thoughts why, first of all, you know, I'm not saying that one is superior over the other, but survival obviously takes into account the timing. And I'm not sure if that's important in your particular research question. But, you know, why did you have to do both instead of like just pick one approach?
Yeah, that was the last part of the paper 3 where I included the survival analysis. I wanted to express graphically how the people in the groups were reaching follow-up based on the days that were informed or not. And so we have a limitation that is the cutoff point is 180 days to be follow-up or not. And so it's like a short time frame of survival, basically. And so I thought that a survival figure could tell the history better than just showing percentages of how much we reach each one of them. So that's why I transitioned into a survival figure there.
So the figure definitely makes it, you know, more informative, I think. Is the timing important in your case? Do you think the timing when the follow-up happened important? Is that important? Because I think that's one thing you kind of like decide. One of the decisions or the things that you have to consider whether you would want like a time to event analysis where you're taking up the timing versus a higher, you know.
Yes. And that's actually a great point. In paper 3, I mentioned that the study by Breslin, they analyze the recommendation type that the patient got. In our program, it was a practice from one of the doctors to describe a time frame for the patient to follow up, like an immediate follow-up. We right now, or 1 month, or 3 months, or 6 months, but that wasn't included in the final standardization. So people is now further evaluation is required in ophthalmology, and so I found like a challenge there trying to adapt into these little different time frames that could be. It's important in the practice. It's important to account for when the patient needs to see the immediacy for the patient to be seen, or else something catastrophic can happen in their vision. But I didn't have that data completely. I don't know, Dr. Watson.
No, it's a great question. And originally, when we first started the program, we did recommend timeframes for follow-up, and eventually realized that most things could wait. And remember, a lot of this happened around the pandemic. And so in many cases, things that we would have ordinarily said, gosh, we'd like to see you next week, we started rethinking just how urgent follow-up would be. Through the use of the program, we've occasionally identified folks who I need to see immediately. In those cases, phone calls were made out to the primary care doctors like that day, even on the weekend. But those are a very small minority. The fact is that diabetes, glaucoma, even retinal vein occlusion are chronic enough conditions. And as long as we can follow up with patients over the course of a couple of months, we're okay. I think the point in setting a 6-month cutoff is at least partially out of the understanding that it's hard to know sometimes whether somebody followed up because they received a positive report or whether they were going to see an eye doctor anyway as part of their annual exam. And it's harder to make the argument that they followed up because of the positive report when it's past half a year.
So Jonathan, from your perspective, does that argue against including the survival curves because time to event is really not relevant in this analysis?
So I think you can still include the figure, but it's more like how you utilize it. From my point of view, you're using it as like a descriptive tool to kind of like describe the timing of a follow-up. Like, for example, I didn't see much of a difference, but for example, you described the slope. Like, for example, maybe greater than 3 days, you know, the slope is kind of like very mild compared to like an initial high slope in the 1 day follow or 1 day follow. So I think if you're using it like that as a descriptive tool to show the distribution of the follow-up timing, I think it makes sense. Unless if all the if like having a shorter follow-up is or if following patients up more immediately is important, I think that that a later follow-up, and I think that is when probably a survival analysis would shed more light or but sure, just looking at whether they had follow-up within 6 months or not, and you're trying to determine the associations, what habits are associated with that, then I think it's, a survival analysis is not legit. So yeah, you're just using it as a descriptive tool. So, I think what I would do is take it as like, we calculated the cumulative from distribution of follow-up and displayed it as a figure. And just leave it at that, I think that's perfectly fine. Rather than calling it like a survival analysis where people are expecting that the timing is actually important.
Thank you so much. Yes, I hear you when you say that, because I've been spending hours travel about the fact that I kind of have a cohort here, but my outcome is dependent on time, yes or no, and these variables are in a single snapshot at the beginning of the process, those kind of things. Thank you so much, Título.
And in fact, I was in the committee. Keep in mind that I can't see y'all, so
There are 10 and Juan will cover hands raised on 2. So, Juan, if you want to go first.
My comment is brief. I want to congratulate Francisco for the tremendous amount of work that he's put into this project. I was delighted to see that you were able to bring it to fruition. My question is related to the comment you made on AI. And we've been told all kind of horrible things that are going to happen to humankind if we don't use AI correctly. Yet it seems to me that here you seem to have enough imaging information to develop the proper machine learning algorithms to make AI perhaps the best way to give Dr. Waxman a break so he doesn't have to read all these images himself. And if you do that, you actually change the time frame that seems to be critical here, not only for follow-up, but for actually intervening. So my suggestion would be hurry up and do a good job as the people in Rwanda did.
Thank you, Dr. Juliana. Thank you so much. Appreciate your words. AI has been in a couple of years in, and the first FDA-approved technology for medicine based on AI was actually for diabetic retinopathy. It was developed by people at the University of Washington, Seattle, and so there are several different forms of AI right now available. Orbis International has their own platform. Some of them are FDA approved. It's a challenge, I think, to decide to move forward with using AI or not for reading purposes and then reviewing them. The study of Rwanda indirectly demonstrates that increased follow-up rates by reducing the time of interpretation. And it's reliable, it's accurate. So yes, those seem like next steps for the program.
But one, clearly I would love to not have to interpret 700 sets of images a month and leave it to the AI to do. Right now, the approved software for doing AI reading does a pretty good job with good images in distinguishing retinopathy from no retinopathy. It doesn't do a good job of reading bad images. I'm better at that than the AI is. It doesn't do anything for detecting diseases that are other than diabetic retinopathy. So one of the things I've resisted is taking a photo that would demonstrate vision-threatening disease and not reporting on that disease just because it's not diabetic retinopathy. I can't allow that to happen. And then finally, and I think you'll sympathize with this, I haven't yet found a way to integrate the AI with Epic in such a way that it actually saves time. Surely the computer can do its job more quickly than I can. But in terms of integrating with UPMC and EHR, it doesn't end up being a time saver. I don't want to address too much to take anything away from Francisco's show, but recently I've had some PGY2 residents help me with the rating, and they'll do a preliminary read before I get to it. But when I go back and do the final read, I'm spending just as much time as if the PGY2 hadn't participated at all. Having a pre-read doesn't actually speed things up.
Thank you.
Let me echo the comments of everyone else, Francisco. You did a fantastic job and a very nice set of presentations and papers. So with my orientation toward cost and cost effectiveness and so forth, I'm wondering about the financial viability questions and what hints or tips would you have for programs who are interested in starting this sort of a screening process in terms of how to handle startup costs and financial viability long-term of this sort of program, and how would that advice differ in the U.S. versus, say, Colombia?
Wow, that's a very good question. I don't think I have the chance to think much about this question in particular. I like a saying that Dr. Watson told me long ago, that it was that the program will be growing as the program will be requesting things to grow. So when I first started, I wanted to have a standardization, to have reports, to have everything, but we didn't have screen rates or follow-up or enough imaging. And so, or a reading center, for example. And these are things that can go from $20,000, which is the camera on the table, and right now it's expensive because the new technology is there, to lots of money, depending on how you're planning to implement the program. The evidence said that it's cost effective. There are studies out there describing different strategies for diabetic retinopathy, analyzing teleophthalmology with single field or 7 fields. I was more interested in analyzing how was this cost effective in terms of preventing blindness based on the follow-up rate. So an extra layer that could be added to this cost-effective analysis is the prevalence of follow-up rate and how following up or not following up will cause an extra cost in the programs. Colombia doesn't have a telemetry program yet, but we have to work towards implementing this kind of technology in other countries and probably replicate the experience in the UK, but they have a national teleophthalmology program. And so these kind of prevention strategies that are demonstrated are effective can be spread around the globe. In the US, there are other challenges, interstate challenges, like who is reading the photos or how the communication goes. But the work is being done, like several places are getting the cameras to work in teleophthalmology right now. So yes, there's still lots of work to do, but particularly in cost effectiveness, we are missing the follow-up variable.
I think Francisco has alluded to the various levels of thoroughness, sophistication, and which one can answer the cost-value proposition. At the very lowest level, you can look at the cost to the system of purchasing a camera and the personnel it takes to run the program versus the compensation we get for taking the pictures and reading the images. At the next level, you recognize that that's actually a very small piece of it, even for the healthcare system, because most of the financial rewards for doing this is based on the fact that it's a quality measure for CMS. And the system is the health plan, the individual practices, the UPMC as a whole is more interested in closing the care gap to achieve better STAR scores and either, depending on how you look at it, reap the reward or not have the penalty of not screening patients for diabetic retinopathy. But what Francisco and I have recognized and lamented about over the last 7 years is that neither of those two things really take into account the cost savings in terms of preventing blindness. The cost savings, back in the step, it's the cost savings of not having a patient go to an eye doctor for an eye exam, right? We can't even quantify that easily, but then take it to the next step of what happens when we don't take a human being out of the workforce because they're blind. What happens when we don't take their family member out of the workforce because they're transported and taken care of someone who's blind? We're very, very bad at quantifying that. And I think this is an important next step that Francisco wants to investigate, is how you start to put numbers on the total cost of losing vision and the benefit of doing the screening to catch diabetic retinopathy and glaucoma and other conditions early so we don't lose people to blindness.
Yeah, and I agree wholeheartedly. The challenge being that the important thing that you want to quantify is not very well quantified, and the upfront costs and the continuing costs are more apparent, but in the long run less important. So my other question is in regards to the evolution story. It really is a very striking story and very well told. I'm wondering how usual or unusual this sort of story is in terms of programs in the US and in terms of programs in other countries?
That's a good question. Everybody tell, as I was describing in the discussion of paper one, everybody tells a story about the project that is more superficial because we implemented this number of cameras and we did it through the medical record system, and that was it. For us, the joint effort that came in 2017 or 18 when we matched the Department of Defense program with the Guerrilla Eye Service Reconnaissance Project is something peculiar, as the 2008 program was one of the first in the country or in the world, but nobody knew that it was actually working. Except for the person reading the photos and the person taking the photos on the other side. So this was an interesting investigation, like a more of an ethnography type. So this is not common in the ophthalmological literature to do this kind of field search and find out the stories of the people and understand what the perception was and how they got a camera. Again, this idea of ordering a camera and proving the concept and then pitching for a grant, I haven't read that in any other place. So yes, that's what is something that calls the attention towards a community participatory effort within this program. And of course, there is that being seen here. Like we have people that work in the project that are passionate about it are here listening to this. I'm very thankful. Happy to see you here. That fills my heart. Thank you again.
Okay, thank you.
Jake, can I make a comment?
Please, Dr. Solano.
Well, Francisco, I can't thank you enough for all the help you gave us in getting this off the ground. For those of you who don't know who I am, I've been intimately involved with the community medicine division since it started. And Jake and I had a vision to put retinal cameras in our practices. But without the help of Francisco, this would never have gotten off the ground. We're at close to 30 cameras now in 100 out of 100 locations. And we've gotten, as Jake mentioned, 5-star ratings in the health plan and some of the other insurers. Unfortunately, United won't pay for DRE camera exams. But without Francisco's determination and will and helping all of our team members getting these cameras off the ground, this success wouldn't have been possible. So just so you know, a 5-star rating means you have 83% at a minimum of your patients getting a DRE. And in all the primary care practices of CMI, plus Altoona, RHS, Williamsport, there's about 77,000 diabetic patients, just to give you an idea of the scope of this. Now, I'm not saying that retinal cameras are the only solution, but they sure did take us over the top. And Ken, for your information, it cost us about $18,000 for a camera, which paid for itself over about 3 years. And hopefully Jake got a bonus for reading all of these exams and getting them back to us in a timely manner. But Francisco was the driving force. He went into all of our practice sites and helped us get this up and running. Then he gave us feedback. He's truly a remarkable young man, and I congratulate him. Thank you.
So much, Dr. Solano. This was a community effort. Rosalind is also here, and she was part of it. This feels more like a part of it than a dissertation for me, but for sure, there is a lot of people to acknowledge and to mention. that was responsible for this. I'm glad that my grain of sand was of some help for the clinics, but also for the patients in our cities. Thank you so much.
Do we have any other committee questions, or can we open it up to the larger group?
No hands raised.
No hands raised. Any other comments or questions from the rest of the group? Please.
Hi,
One at a time.
I'm Anna Gelby. I'm a director of a family health center that has trainees, and I was interested in the low percentage of eligible providers who actually order. I think it was 50%.
But in the ethnographic experience that I have, some people were just resistant to the fact of using the cameras.
I want to echo Dr. Solano's comment that it really helped to have you come out and troubleshoot and help train us, because we also have turnover in our staff as well. So we really appreciate your help.
Thank you. And that turnover is what I wanted to highlight when I was mentioning primary pharmacy health camera. They have this all-night working for 10 years. With no training, no supervision, because the person that was doing the photos was doing the photos for 10 years. So she had her things, so when she wasn't there, of course nobody was taking the photographs. But that shouldn't be the case. The program should be easy enough for everybody to use it. That's why we created booklets to spread across the clinics with instructions of how to, where to go if they have problems, etc. Like we try to avoid also a syndrome that Dr. Watson named the camera in the closet syndrome, which happened to me a lot. Like I asked him, where do we have cameras? He will say different sites, but we don't have photos from there. So I will pay them a visit, out of the blue probably, and I will be, where is your camera? And to find out that that was a real syndrome. Still haven't been described in the literature, but word of mouth, they have a camera hidden in a closet. I grab the camera, we talk, we put it in another center that wanted to use the camera. So yes, the implementation process is long and requires lots of work and lots of patience. But also the human factor is what I want to highlight. Like when implementing things, it's not only about the money that's going to produce or the stuff that's going to reach, but also how are you selling this to people. And I'm not a seller, of course, I'm a physician, but I saw myself as a person going into the doors and trying to convince them that, listen, this is gonna do so much for the clinic, not only for your stars, for your benefits, bonuses, but also for your patients, saving them time of life, things like that. And so finding the right strategy to get the buy-in was like one of the main points. Okay. Dr. Ignacio?
Yeah, I have several questions.
Okay. Of course.
Yeah. Okay. That was very interesting, the comment about the left eye photo being ungradable. Like, that was very interesting, actually. So I appreciated hearing that. Piggybacking on the question about cost effectiveness of all this, can you talk a little bit about kind of this project throughout its whole duration buying these cameras? Have you had to replace any cameras in any of the sites at this point? Have any of them had any major issues with breaking down, or are you really using the original cameras in these locations?
So the cameras from the Department of Defense were changed, were upgraded to the DRS NLP cameras.
Okay.
There have been issues with some cameras, but they were covered by warranty, and then when CMI joined, they got a widespread warranty for all their cameras. And so, in my experience, there hasn't been major problems with the camera. Like the technology is simple, the machines require very little maintenance, and the company was still easily reachable when I was working in the program. I don't know, Dr. Watson,
They are remarkably resilient. Some of our very first cameras are still in operation. Birmingham Clinic recently dropped their camera. Keysport 9th Street actually lost the camera in a fire as the Keysport 9th Street Clinic caught fire. We've had some hard drive failures that have had to be replaced in my north side camera probably needs a repair because of scratches on the lens. But on the whole, they're remarkably resilient. And I think we have some cameras that are in operation continuously for the entire duration of the program.
Wow, that's great. And then would you please speak a little bit more to, you have the no-show rate slide there, where I think it was 1%, every 1% no-show rate.
It's 4%.
Yeah, can you explain that? So was the first statistic the one for every 1%, is that like a PCP no-show rate?
Is that
For every
in the
1%?
system?
Yeah,
Yeah,
okay.
good question. So yes, that's for the whole system.
Okay.
So in Epic we have this statistic where the demographics are like a no-show rates for the patients. So we grab that there from there. And so the variable was analyzed quantitatively, meaning it didn't have categories, it was like a 0, 1, 2, 3 no-show rate. And so the loss ratio being positive is associated with loss to follow-up, and for each unit in the decimal point that is increased, it's an increase in the likelihood for not following up. So it was a 0.4 odds ratio, 1.4 rate odds ratios, that little, if I can see it really quick also. Yes, when we're increasing the no-show rate, it will be an increase in the likelihood to be lost to follow-up. And so it's kind of like linearly correlated. Increasing the no-show rate, of course, you have a likelihood to not follow up.
It's interesting because the very nature of this program is to reach people who weren't making it for their eye exam in the first place. So there's a tendency to no-show built into the cohort. And then what Francisco has shown is that the more evidence there is of not showing up for any appointment, the more likely it is that we don't get you to follow up at all. And so one of the things he and I have talked about over years is a next step of doing sort of a precision social determinants study where what intervention do we need for what patients to get them in? Who needs a phone call? Who needs a text message? Who needs a social worker knocking on their door? Clearly, we can't afford to have a community health worker knocking on everybody's door. But maybe we need to, for a subset of patients, that we can identify based on their EHR characteristics.
Yes.
And we didn't quite get to that in the third paper, but maybe paper 4.
That also,
We can take 1 or 2 more questions, but unfortunately we need to wrap things up. Anything from our audience, our Zoom audience?
thank you, very pleasure.
No hands raised right now.
No hands raised. Anything left for the in-person folks?
I was just curious about the no insurance people, you mentioned it on the slide towards the end. I was curious, just, were there a lot of patients throughout this time with no insurance, and were there any associated findings with that group?
No, in the model, we have a very little proportion of people without insurance in the program. In the final model, we try to analyze all others, compares again Medicaid, and we didn't have this significant. So it wasn't associated with being lost for the type of insurance that people have. But it has been reported in the literature that not having insurance could be associated. The problem with the previous study is that they were looking into particular populations or a single center. So it was very limited research. Thank you so much.